Hello, and welcome to the Tune In to Safe Healthcare webinar series featuring today's presentation, Making Dialysis Safer for Patients, Optimal Vascular Access, hosted by the Centers for Disease Control and Prevention. My name is Preeti Patel, and I'm a medical officer in the Division of Healthcare Quality Promotion at CDC, and the director of the Making Dialysis Safer for Patients Coalition. This webinar is a part of a series of infection control-related webinars that CDC hosts, along with a variety of external partners and experts. We thank you for tuning in today, World Kidney Day 2019. Before we get started, we have the following disclaimers to show. And the following disclosures. This webinar is accredited for physicians, nurses, pharmacists, certified health educators, public health professionals, and other health professions. The next two slides show the accreditation for continuing education. Instructions for obtaining continuing education will be provided at the end of the webinar. It is now my pleasure to introduce our main speaker for today's presentation, Dr. Kazakova. Dr. Kazakova is a health scientist in the Division of Healthcare Quality Promotion at CDC. She completed her medical training in Russia, obtained her master's degree in health services at Boston University School of Public Health, and doctoral degree in health policy at Johns Hopkins Bloomberg School of Public Health. Her doctoral research was focused on access to primary care in the United States and its impact on individual health status. She has previously worked at the Agency for Healthcare Research and Quality, AHRQ, where she assisted with analyses of large Medicare databases. Dr. Kazakova has also completed CDC's Epidemic Intelligence Service, or EIS, training program, during which time her investigations and other work were focused on healthcare-associated infections. I will now turn it over to Dr. Kazakova to present to you a study she led on incident vascular access and risk of bloodstream infection among new ESRD patients receiving hemodialysis.
Thank you so much for the opportunity to present the analysis that were conducted by a group of epidemiologists and clinicians in the Division of Healthcare Quality Promotion of CDC. According to the title, the focus of the study was hemodialysis vascular access, and more specifically, incident access. Incident means or equals to being first. It is the very first access used at dialysis initiation, and during the presentation I will refer to incident catheter, fistula, and graft use. In addition to incident access, the study looked at prevalent access, which is defined as vascular access continually used during a period of time. And similarly to incident access, I will refer to prevalent catheter, fistula, and graft use. According to the most recent U.S. Renal Data System report, in 2016, there were over 700,000 end-stage renal disease patients in the United States. Of those, 63% were treated with hemodialysis, which requires reliable access to the bloodstream. Among the three types of accesses, fistula is the first choice because of better longevity and lowest rates of complications, including infections. Grafts may also be the first choice, particularly among children and patients with peripheral vascular disease. Catheters are important as well, especially for patients requiring urgent dialysis or those whose permanent access failed. Although catheters can be placed in a timely fashion, they have been linked with severe complications such as bloodstream infections and therefore are not recommended for long-term use. In recognition of the advantages of fistula, in 2003, the National Fistula First campaign was initiated to increase prevalent fistula use among end-stage renal disease patients on hemodialysis. And in fact, prevalent fistula use increased from 32% in 2003 to 63% in 2017. In this graph, prevalent fistula use is represented by a blue-green line at the top and prevalent catheter use by brown and orange lines at the bottom. As you can see, the significant increase in prevalent fistula use corresponded only when a small incremental decrease in prevalent catheter use. When we look at vascular access use from the perspective of a new patient, since 2005, about 80% of all incident patients have been initiating hemodialysis with catheter, and this trend has not changed since 2005. This graph shows the relationship between incident and prevalent access, where the outer portion of the circle shows the relative proportions of new and prevalent patients contributing to the prevalent access count. As you can see, the majority of prevalent catheter use count, which is in blue, comes from new patients, confirming the importance of incident catheter use. In addition to tracking incident access, it is important to understand how initiating hemodialysis with one access versus another affects health outcomes. To date, there have been several observational studies that examined incident access and found that initiating dialysis with fistula was associated with better survival, lower rates of vascular access-related hospitalizations, and lower costs. However, every observational study can be subject to potential selection bias, where healthier patients might be more likely to obtain fistula, and those in need of urgent dialysis and ineligible for fistula more likely to use catheters. This highlights the importance of controlling for patient health status and other characteristics potentially linked with both vascular access and health outcomes under the study. In light of the evidence and also its limitations, we conducted a study with the goal to estimate the risk of acquiring bloodstream infection by vascular access type at dialysis initiation during the first year of hemodialysis. To address the selection bias, we control for patient characteristics or confounders that could impact patients' chance of obtaining fistula, such as health status. To achieve the study objective, we used a retrospective cohort study design with a population of new end-stage renal disease Medicare beneficiaries on hemodialysis as the only mode of renal replacement therapy, who started hemodialysis between January 1, 2011 and December 31, 2012. And lastly, we selected only patients with a continuous fee-for-service Medicare coverage for 2 years before and 1 year after the initiation of hemodialysis or until time of death. The study was completed by utilizing institutional and non-institutional claims from 2008 through 2013 for a random 5% sample of Medicare beneficiaries. Our key exposures were incident and prevalent vascular accesses, which were determined from monthly outpatient dialysis claims submitted during the first year of hemodialysis, where a vascular access was recorded in revenue center codes V5, V6, and V7 for catheter, graft, and fistula, respectively. This information on vascular access was found to have an excellent level of agreement with that reported in the medical evidence form. The outcome of interest was incident hospitalization with bloodstream infection during first year of hemodialysis and was determined from inpatient claims using previously validated ICD-9 codes for septicemia and bacteremia. To address potential selection bias, we adjusted our analysis for a number of patient characteristics available to us through insurance claims. First, we created a Gagny-Core morbidity score for each patient, which is a validated predictor of 1-year mortality and incorporates a number of current and past comorbid conditions, such as hemiplegia, metastatic cancer, and complicated diabetes. It is constructed based on diagnostic codes from inpatient claims in the year prior to dialysis initiation. We also controlled for a number of chronic conditions, such as chronic heart failure, stroke, cancers, chronic obstructive pulmonary disease, just to name a few. We used inpatient location of first hemodialysis as a marker of urgent start of hemodialysis and prior healthcare utilization as indirect measure of health. Prior healthcare utilization was measured by total Medicare reimbursement during baseline and was estimated using claims from across all healthcare settings, such as inpatient, outpatient, home health, skilled nursing facilities, as well as physician and medical equipment claims. And lastly, we controlled for patient demographics such as age, race, and sex. For analysis, we used chi-square and students' t-tests for categorical and continuous variables, respectively, to compare incident vascular access groups. We used survival analysis with Kaplan-Meier curves to compare event-free times for each study group. And we applied a novel method of survival analysis with multivariable extended Cox proportional hazards regression models that allowed us to estimate the risk of bloodstream infection by not only incident access, but also by time-dependent prevalent access. And next, I will present results of the analysis. This graph describes how our study cohort was selected. In brief, from the 5% random sample of Medicare beneficiaries, 15,583 had end-stage renal disease in 2011 and 2012. Of those, 3,174 were new end-stage renal disease patients with a complete Medicare fee-for-service coverage. After excluding patients who changed their mode of renal replacement therapy during the first year, initiated peritoneal dialysis, or obtained a renal transplant, we had 2,392 patients selected in the study. Of those, 1,900, or 79%, initiated hemodialysis with catheter, 82, or 3%, with graft, and 410, or 17%, with fistula. Next, I will present a comparison of key patient characteristics by incident vascular access groups. First, I would like to highlight age. Among the three study groups, the mean age was 78. And compared to catheter and graft starts, patients starting with fistula were more likely to be white and male. This table shows the distribution of patient characteristics such as deaths during follow-up, initiation of dialysis in hospital, and number of incident hospitalizations with bloodstream infection by incident access groups. According to the results, the proportion of patients who died during the first year was 38% among catheter starters, compared to 13% among fistula starters. 84% of patients starting with catheter obtained their first hemodialysis in the hospital, compared with 44% of patients starting with fistula. Hospitalization with bloodstream infection was the main focus of the study and was assessed for every patient during the follow-up. Significant differences in frequency of incident bloodstream infection were identified among the study groups, where 29% of patients in catheter start group had at least one hospitalization with bloodstream infection, as compared with 10% of patients in the fistula start group. The unadjusted rates per 1,000 patient days for each incident access group are presented here. According to the results, the rate of bloodstream infection was 1.5 among catheter starters, which was significantly higher than the rate of 0.4 in patients starting with fistula. The differences in bloodstream infection hospitalizations can also be seen in these Kaplan-Meier curves, which show the probability of survival without BSI during the follow-up. Survival times in our analysis were censored at time of death, acquisition of BSI, or end of study, which was the end of the first year after dialysis initiation. Patients starting with fistula are represented by the shallow red line, graft starters by green line, and catheter starters by blue. As evident from the graph and also from the log rank test, patients initiating with fistula were significantly more likely to survive without BSI than the other two groups. This table presents the distribution of some of the chronic conditions included in the study. In general, chronic conditions were more prevalent among catheter starters than among those initiating with graft or fistula, with the exception of anemia, which was equally present among the three groups. Conditions that were particularly more prevalent among catheter starters were congestive heart failure, ischemic heart disease, and rheumatoid arthritis. In addition to these conditions, our analysis examined and controlled for diabetes, depression, stroke, different types of cancers, asthma, and hypothyroidism. Also, Gagny comorbidity score of 1 or greater, indicating increased likelihood of death, was significantly more prevalent among the catheter start group. Our assessment of transitions between vascular accesses during follow-up showed that half of patients starting dialysis with catheter never changed or transitioned to a permanent access. Among patients initiating dialysis with permanent access, we found that 71%, 81% of graft and fistula starters respectively used their initial access throughout the follow-up and never changed it. Among the patients that did change their permanent access type during the follow-up, the highest frequency of change occurred among graft starters, where 29% of patients used a catheter at least once during the follow-up. To estimate the risk of acquiring BSI, we fitted two multivariable regression models, adjusting for age, sex, race, chronic conditions, location of first hemodialysis, Gagny comorbidity score, and baseline healthcare utilization. Model 1 included Incident Vascular Access plus Confounders, and Model 2 included time-dependent prevalent access and Confounders. According to the results of Model 1, after adjustment, the risk of hospitalization with bloodstream infection was 67% lower among fistula starters as compared with those initiating with catheter. The incident use of grafts was not significantly different from the incident use of catheter in terms of the risk of BSI. In Model 2, the prevalent use of either graft or fistula was associated with significantly lower risk of BSI when compared with prevalent catheter use. Results of this analysis should be interpreted in light of its strengths and limitations. Among the strengths are the study's use of a contemporary national cohort of end-stage renal disease patients and its ability to control for various potential confounders. Having healthcare utilization data from the entire spectrum of services delivered to this population, we had the ability to censor the follow-up at critical events such as changes in model of renal replacement therapy and death. The use of a novel method of extended survival analysis allowed us to estimate the risk of BSI associated with time-dependent prevalent access and to compare the risks between incident and prevalent accesses. As a retrospective study using administrative insurance claims, this analysis is a subject to a potential misclassification bias in our exposure because dialysis providers in their monthly reports are required to report only the last access used during the month. The actual incident access may be different from the one reported to the CMS. Prevalent access may also be affected by the inaccurate reporting. However, the misclassification is likely to occur at random, affecting all access categories equally. Second, although we controlled for a number of patient characteristics, there is still a chance for potential residual confounding. For example, we did not have information on pre-dialysis nephrology care, which is by far the most important predictor of both early fistula use and better health outcomes. And lastly, because our study included a population of elderly patients, there is a limited generalizability due to age. In summary, this study, using a contemporary national cohort of new end-stage renal disease patients on hemodialysis, found that initiating with fistula was associated with significantly lower risk of acquiring BSI in the first year as compared with catheter initiation. Initiating with graft was not associated with lower risk of BSI, but prevalent use of either fistula or graft was associated with lower risk of BSI than the prevalent use of catheter. And we determined that transition to another vascular access type among patients initiating with graft likely accounted for this difference in incident and the prevalent graft use associations. In addition, contrary to our expectation, this analysis revealed that only 17% of Medicare beneficiaries with a 2-year complete continuous pre-dialysis fee-for-service Medicare coverage initiated hemodialysis with fistula. And lastly, we found that 84% of catheter and 44% of fistula starters initiated hemodialysis in the hospital, resulting in a higher resource use and cost to CMS. In conclusion, we would like to highlight several implications of this work. First, it demonstrated that reducing dialysis and placing fistula as a permanent hemodialysis vascular access prior to initiation of dialysis could prevent significant infection-related morbidity and subsequently costs associated with preventable hospitalizations. Second, persistently low use of fistula at hemodialysis initiation among Medicare patients with full coverage suggests that insurance is important but insufficient by itself to ensure optimal access. And lastly, we would like to mention that there are additional recognized challenges for early fistula use, such as barriers to pre-dialysis nephrology care and chronic disease management, and initiating hemodialysis in a hospital. These are all potential areas for improvement. And this concludes my presentation. Thank you again for the opportunity to present and share these results, and also for your attention.
Thank you, Dr. Kazakova, for that presentation. As you all heard previously, I'm the director of CDC's Making Dialysis Safer for Patients Coalition. Through this coalition, we work together with a broad range of partner organizations to prevent bloodstream infections. The topic of optimal vascular access and the findings from this study are extremely pertinent to what we aim to do within the coalition. CDC has a list of what we call core interventions for dialysis bloodstream infection prevention. This list, the explanation of each intervention, accompanying tools, and other resources to support adoption of the interventions are available on CDC's Dialysis Safety website. We encourage all dialysis facilities to utilize these interventions to prevent bloodstream infections. The intervention I'd like to highlight today involves vascular access optimization and specifically catheter reduction. Facilities are asked to pursue efforts to reduce the prevalence and use of catheters by identifying and addressing barriers to permanent vascular access placement and catheter removal. There are many types of efforts that can be pursued to decrease catheter use. Today, we are grateful to have several experts from the Canadian community joining us to help discuss their experiences around vascular access and catheter reduction. I'd like to introduce our discussants and facilitator. Leading the discussion is a colleague of mine, Dr. Ronke Apata. Dr. Apata is a nephrologist in the Division of Healthcare Quality Promotion at CDC and an assistant professor of medicine at Emory University School of Medicine. Dr. Apata provides care to patients on the renal consult service at Grady Hospital in Atlanta, Georgia. She is a co-chair of the Patient Engagement Workgroup for CDC's Making Dialysis Safer for Patients Coalition and a project committee member for ASN's Nephrologists Transforming Dialysis Safety Initiative. Dr. Apata's dual roles as a public health professional and practicing nephrologist have given her a unique and valuable perspective on dialysis patient safety. Our discussants today are Dr. Vandana Nair and Dr. Tracy Janellis. Dr. Vandana Nair is a professor of medicine in the Division of Nephrology at Emory University. She completed her internal medicine residency training at the University of Louisville and her nephrology fellowship at Emory University. Dr. Nair has been a member of the faculty at Emory University since 2006. Dr. Nair's main clinical interests and areas of expertise are end-stage renal disease and management of vascular access in hemodialysis patients. She is proficient in dialysis access procedures and in renal ultrasonography. She's passionate about promoting multidisciplinary collaboration in vascular access research and education, with the ultimate goal of optimizing access care and processes for dialysis patients. Dr. Tracy Janellis is a nephrologist and one of the core physician leaders at Kaiser Permanente. Inspired by the strength of people living with kidney conditions, she has worked tirelessly toward creating one of the most respectful and high-quality kidney care programs. She is passionate about patient-centered care. Together with her team of nephrology care providers, she strives to create a culture and a system that delivers seamless care transitions between medical treatments, surgery, dialysis, transplantation, and supportive care services. I thank each of our experts for joining us today and would like to turn it over to Dr. Apata to kick off the conversation with questions for our discussants.
Thank you, Dr. Patel. I'd like to direct our first question to both Dr. Janellis and Dr. Nair. Dr. Janellis, in your experience, what have you found to be the greatest challenge to reducing catheters?
Greetings from San Francisco. This is Tracy Janellis for a sound check. Am I okay coming across?
Yes, you are.
Great. Dr. Patel and Dr. Apata, thank you for the introduction. Dr. Kazakova, I appreciate your in-depth analysis. It provides valuable information confirming the benefits of fistula for hemodialysis initiation. We have a lot of talent here in the audience. In this audience, we have a lot of talent. So the strategies and the tools we discussed today are just meant to be ideas to spread and to scale up. From the patient's perspective, it is a terrifying experience to face end-stage renal disease as they walk the journey from CKD to ESRD. In our experience, the greatest challenge and the greatest joy is to help patients navigate the complex steps of CKD to ESRD care. Well-coordinated care can positively affect patients' perspective of living with CKD and ESRD, reduce barriers to care, ease fear and anxiety, move patients along the appropriate pathways, and provide a safety net to prevent fall-throughs. For example, a proactive approach to goal-of-care discussion and life care planning, shared decision-making, including the choice of maximizing medical therapy without dialysis, can provide better quality of care. For those who choose dialysis, education and empowerment for patients to choose home modalities or prompt placement of and monitoring of hemodialysis accesses can all lead to reduction of CVC. Therefore, through seamless care coordination, we can positively change the patient's outlook and lead to reduction of CVC. To address the challenges of coordinated care, we have developed 3 tools. On the left is a hemodialysis access playbook to map out the entire care process, end to end, from the time of primary care referral to the initiation of hemodialysis, with examples of best practices across 21 medical centers. The right upper picture is a weekly status report and catheter tally for each medical center. As you can see, there are patient information, care team information, information related to the procedures, be it ultrasound or vascular appointment or access procedures, the status of patient. For example, on this is RRT status. It could be CKD or it could be hemodialysis. The access type related to the modality and other information could be placed on the report as you can see fit. Based on this status report, the care coordinators will be able to take appropriate actions. For example, if a patient is no-show to vascular surgery or OR, or fistula is overdue for ultrasound, follow-up actions can be taken. So this patient happens to be a PD patient with a PD catheter. She's getting a fistula placed in preparation of PD failure. And under the RRT status, say if this is a hemodialysis patient with access type of catheter, the team can then review and take actions leading to catheter removal. In 1796, 200 years ago, Blossom the cow and the little boy Phipps had no idea of their contribution to the world free of smallpox today. Imagine the world without hemodialysis CVC, hopefully in less than 200 years. So if we move our eyes lower to the right lower picture of a CKD dashboard, this is a CKD dashboard that we took advantage of the Kaiser Permanente electronic medical record system to automatically pull information and cast a wide safety net to enhance early CKD referral from primary care to nephrology. If a patient meets certain criteria on the EMR, his or her record will pop up on our CKD dashboard. And this dashboard is managed by the nephrology group. We have observed significant improvement in the outcome of the Kaiser Permanente's Optimal Starts program through this systematic approach and culture change. In Kaiser Permanente Northern California, 33% of new ESRD patients start with home modalities. In the higher performing medical centers, home dialysis start reached 40 to 50%, and fistula starts for hemodialysis are at high 60s%. Thank you.
Thank you. Navigating the healthcare system can be daunting for patients. Dr. Nair, I would like to ask you the same question. In your experience, what have you found to be the greatest challenge to reducing catheters, and how have you attempted to address this challenge?
Thank you. And thank you, Dr. Janellis, for that elegant discussion on the challenges in the CKD population transitioning to dialysis. I'll now focus on those patients that we see in the dialysis unit, those who are already dialyzing with central venous catheters. The biggest challenge here is getting timely appointments and interventions, not just for placement, but also successful use of permanent accesses, so that once the patient has transitioned, we may be able to remove the catheter in a timely manner. At Emory, we've tried to address this issue by coming at it from multiple perspectives. The patient is at the core of this process. It's critical to educate and involve the patient and get their buy-in, because unless the patient is vested in this process, it will be difficult to get the results we need. And it's essential to start early. At our dialysis unit, we make it a point that every new patient dialyzing with a CVC gets a surgical consult and a vascular mapping appointment within the first 2 weeks of starting dialysis. The other thing we've done at Emory is to organize a vascular access team. We have 2 vascular access coordinators who are experienced in the ins and outs of vascular access, who spearhead this process, and really they're the backbone of this process. We do weekly rounds on all our catheter patients where we discuss every one of them in detail. We discuss their comorbidities, look at their op reports, and plan the next steps. and record everything on an Excel spreadsheet that we update on these weekly rounds. In addition to that, we also do focused access rounds on a rotating basis where we go around our dialysis units. We have 4 dialysis units with around 600 hemodialysis patients spread all over the city, and we examine and evaluate the accesses at the chair side. We're also fortunate here at Emory to have great working relationships with our vascular surgeons and interventionists. In order to expedite care, we were able to convince our surgeons to give our patients multiple appointments across the timeline. So when the patient gets the surgery appointment, at the same time, they also get a 2-week and a 6-week follow-up appointment from the day of surgery. At the 6-week appointment, the access is evaluated. If it looks like it's maturing and will be ready for use, that's fine. But if it needs an intervention, it's scheduled right away and acted upon. On our end, in the dialysis unit, we also back up this process and continuously follow and examine the access. The 6 weeks post-op date is marked on the calendar, and the access is re-evaluated around that time until we have a functional access. And once the access is ready, we have an understanding with our surgeons that we in the dialysis unit can decide when to cannulate, instead of having to send the patient back to the surgeons to get an okay to cannulate, and that saves our patients at least a couple more weeks of further catheter dependency. All of these measures and our team approach allow us to get functional permanent accesses in a timely manner and help us to reduce our catheters.
Thank you. This was very helpful. Both of you have demonstrated the multifaceted approach needed to decrease catheter use, and it's great to see your efforts have shown positive results. Moving to the next question. Dr. Nair, can you describe one aspect of your vascular access program that you feel has been particularly effective?
Sure. So as I mentioned earlier, one aspect of minimizing catheters is not just placing new permanent accesses, but also maintaining an access that's already in place and minimizing infiltrations. And infiltration is the bruising of the access that occurs if it's not being cannulated properly. A unique aspect of our vascular access program is ultrasound guidance for cannulations, and we have modified our cannulation protocols to reflect this change. We have now trained our vascular access coordinators in the use of basic ultrasound, and they mark all new AV fistulas and difficult AV grafts with ultrasound and provide a visual map for cannulations. Each dialysis unit has also identified cannulation experts who function closely together as a team, and only members of these previously identified cannulation teams can cannulate the accesses. Anecdotally, we have seen our infiltration rates drop, and we are now collecting data prospectively to look at the effects of our policy in the long term.
Thank you. Do you know how widespread the practice of using ultrasound-guided cannulation is? Is it likely to grow over time?
I think we are one of the few units using ultrasound guidance for cannulation, but I'm sure it will grow over time as we are able to prove a decrease in the infiltration rate and thus decreasing the catheter prevalence time.
Thank you. Dr. Jonelis, can you describe one aspect of your vascular access program that you feel has been particularly effective?
Absolutely. So thank you, Dr. Nair. You called out the crucial steps in the preservation of fistulas. It is great that we can share ideas and experience from 2 different care environments with one common theme, putting the patient front and center. Here in Kaiser Permanente, we took advantage of our integrated care system and created a one-stop shop nephrology, vascular surgery, ultrasound joint clinic to monitor the newly placed permanent accesses, particularly for the pre-ESRD patients. In this joint clinic, patients are evaluated by nephrologists, vascular surgery, care coordinators, and get their ultrasound done all at the same visit. Patients appreciate multidisciplinary team approach. when they hear the same message from all their providers, they feel confident in their care. In return, the care team finds joy and meaning in practice. Marginal fistulas matured with prompt intervention and close follow-up, and some of the fistulas that initially looked great were found to have serious problems and were salvaged prior to dialysis initiation. And this is one of the crucial steps in terms of preventing fistula failure, which could be rather common in some of the other practice settings. And we hope to share this experience and to share the results of this experience. It has spread to many other medical centers within Northern California, Kaiser Permanente, and we have reported initial findings as an ASN abstract in 2018. Thank you.
The one-stop shop sounds great in helping streamline the process for patients and improving communication between nephrologists and vascular surgeons. How have nephrologists and surgeons responded to this strategy? How do they like it?
They love it. Initially was a little bit of a slow start, and we booked less appointments and seeing less patients. But as time passed by, everybody, all the kinks are working out, and we can pretty much see about 20 to 22 patients in about 2 to 3 hours. We are actually running the clinic as of today, this morning. It's no problem. It's a little bit of coordination for the providers to come together, but the results and the satisfaction from the patients really gives very positive feedback to the care team, and we felt great. After each clinic, it's a great feeling that the patients get really good care.
That's great. Thank you. Dr. Janellis, what educational strategies or resources have you found to be most effective when talking to patients about having a fistula or a graft placed?
Right. So we went through a bit of a combination and trying to really find what's the key and most effective component of all the CKD and ESRD education that we have done through the past many years. And what we found is one picture is worth 1,000 words. Visual aids are very effective in educating patients regarding the risk of CVC complications, including infection, thrombosis, and late stenosis. It helps to promote placement of fistula. We also use visual aids to promote peritoneal dialysis. For example, by showing a PD catheter in a model tummy, it helps to convert CVC to PD catheter. We use Kaiser Permanente CKD education material made for adult learning. We provide live education either in small groups or one-to-one. We also use online videos for those who cannot attend in person. Peer-to-peer or patient-to-patient education and share experience is also very effective. If there is a willing patient with a fistula, shows and tells his or her story, other patients are more receptive to fistula placement. Kaiser Permanente Northern California ESRD patients are spread to over 100 hemodialysis clinics. Strategically, KP nephrologists function as medical directors in some of the larger contracted dialysis clinics to enhance the KP culture of high-quality care. Thank you.
Thank you. I agree. Visual aids can be effective in patient education. I often show pictures of fistulas to patients initiating dialysis with a catheter in the hospital. It helps to improve awareness and education on the importance of being evaluated for a fistula or graft. I will start showing pictures of catheters and its proximity to the heart to underscore the education on the risk of catheter use, particularly infections such as endocarditis. Dr. Nair, I would like to ask you the same question. What educational strategies or resources have you found to be most effective when talking to patients about having a fistula graft placed?
I agree with Tracy. Patient education is the key to informed decision making. At Emory, we've made a dialysis options video that is freely available on YouTube. It's not just limited to our patients, and the URL is up on the screen. We show this video to our CKD patients in the clinic to help them know more about all the different options available to replace their kidney function: transplant, peritoneal dialysis, and hemodialysis. And within hemodialysis, the differences between fistulas, grafts, and catheters. We also offer a monthly in-person class at one of our dialysis units where patients can discuss their options in detail, and they have the opportunity to ask questions and actually see the in-center dialysis patients. In all of these educational options, we emphasize peer interactions and patient-to-patient discussion with patients describing their own perspectives, as that is so much more meaningful than a provider talking to the patient.
Making an educational video for patients that's accessible and free to patients is definitely commendable. How has the video been received by patients, and have you received any feedback?
So far, I just checked that yesterday. There are around 450 views on the YouTube site. I do know anecdotally from the patients that have started dialysis that they felt that the video helped them to be more educated, not just about the different modes, but also the different things like home dialysis, nocturnal dialysis, and peritoneal dialysis. So a lot of our patients have really come back with being very appreciative of that video.
That's great. Thank you. So Dr. Nair, thinking to the future, what innovations or ideas are needed to assist with early optimal vascular access placement?
To me, the number one most important thing is a team approach. Once we place the patient at the core of our processes, and all of us, nephrologists, surgeons, interventionists, nurses, and technicians, acknowledge that we're all part of the same team and work together collaboratively, we can achieve the optimal access for each patient. The upcoming revision of the KDOQI guidelines are also built on this foundation, making sure that we have the right access for the right patient at the right time and for the right reasons. An innovation that I'm really excited about is the endovascular AV fistula options. There are two new devices that allow for a patient to get AV fistulas without open surgery, and both of them have just been recently approved by the FDA. One works with magnets and the other is a thermal device. At this point, we only have preliminary data for both of them and not the long-term effects, but they both seem very attractive options for those subsets of patients who would be a candidate for these procedures. Their advantage over open surgery is that they are minimally invasive and the procedure can be done as an outpatient. Even more importantly, the endovascular fistulas overall require less time to mature. In the initial studies, most of them have been cannulated relatively early after placement, so that would again help to minimize catheter time. There are certain limitations as well, including the need for secondary procedures and their overall lower blood flows. But this again emphasizes the importance of a team approach towards these accesses.
Thank you. Dr. Journalist, thinking to the future, what innovations or ideas are needed to assist with early optimal vascular access placement?
Thank you, Dr. Nayat. Dr. Nayat astutely pointed out two of the most important aspects of vascular access care: team approach and technological advancements. The magic and the solution lie within our patients. We will have to continue the culture of patient-centered care, adding co-design and patient voice to improve the experience and value of ESRD care. Thank you.
Thank you both for highlighting the importance of a team and coordinated approach in vascular access placement and maintenance, and sharing your efforts and innovative ways to make the process easier for patients, such as the one-stop shop, combined vascular surgery and nephrology clinics, patient visual aids and videos, peer-to-peer education, and ultrasound-guided cannulations of fistulas. Patients form relationships and trust with different members of the team, such as dialysis techs, nurses, dietitians, social workers, and nephrologists. So we all have a role to play in achieving optimal vascular access. Thank you both for your time and expertise, and a special thank you to the Coalition team for organizing this webinar. I would also like to thank everyone for tuning in today, World Kidney Day 2019. If you're interested in learning more about CDC and the Making Dialysis Safer for Patients Coalition work to protect dialysis patients and reduce infections, please email us or check out our website. And last, to obtain continuing education for this presentation, you will need to visit the TCEO website at www.cdc.gov/getCE. If not previously registered, you'll need to complete a short registration process. Once logged in, you'll then utilize the Search Courses tab and type in WC 2720-031419. Choose the option for Making Dialysis Safer for Patients Optimal Vascular Access. And in order to receive continuing education, you need to complete the evaluation and post-test, scoring at least 80%. You can then go to the Transcripts and Certification tab to download your paper certificate if needed. There are no fees for this continuing education. Thank you for joining us, and have a great afternoon.